I think most people are on. Good morning. Nice to have everybody up for our grand rounds. We're very lucky to have Seth Glickman here speak to us about transforming healthcare markets. Seth was President Executive Medical Officer at University of North Carolina. And then for anybody who's been to Salt Lake City and knows about Intermountain Healthcare, he was president there from 2018 2020, and then became Chief Medical Officer at Blue Shield of California, and now more recently is at Reserve Therapeutics. You know, for all of us who deal with patients on it every day, the black hole for us is how the insurance companies interact with the delivery of care. And I think Seth's going to give us some insights into healthcare plan strategies and operations and the perspective from the healthcare insurance perspective. So Seth, we're very happy to have you here and we're looking forward to your talk. Thank you very much for coming.
Outstanding. Thanks for having me. I'm going to transition over here to my slides. If you'll just give me 1 second. Okay.
There you go. That looks good.
Yeah.
And for everybody, if anybody has questions, feel free to put the questions into the chat or the question and answer. We'll deal with that as we go through.
Okay, great. Well, thanks for the intro. I'm really excited to speak with everybody today. I was a former colleague of Dr. Pruthi at UNC, and he was a great collaborator, and he reached out to me a few months ago and asked if I would be willing to share some of my perspectives with your faculty, and I'm really happy to do so. I'm going to talk today about transforming healthcare markets, and the focus is really going to be around value-based care, and as Marshall said, the intersection of care delivery with what health insurance companies do and how they finance healthcare delivery, and how we can create more synergy between the two. And I think also try to leave you with some practical tools or things to think about how to advance your work and your practices in sort of a new framework that I think healthcare is headed. So just a quick disclosure, as was mentioned, I'm now CEO of Reserve Therapeutics, which is a very early startup pharmaceutical services company that's spun out of Stanford. The topic of my talk today is not related to the work that Reserve Therapeutics is doing, so there's no conflict there. So I just thought I'd share a little bit about my life over the last 2 years. It's been crazy, I'm sure, like all of yours, and hopefully we're all returning to a period of relative normalcy or a new normal. I've spent a lot of time playing piano over the last 2 years, and my wife is a pianist. She's better than me. And we found ourselves playing so much and spending so much time inside that the picture on the left, we actually had to buy 2 pianos. I never thought I would do that. And I rejected her offer to buy a second Steinway because I would have had to take out a large loan. So that's me playing our small electronic piano, which is still a good piano, and you can put on headphones so we can actually both practice without wanting to kill one another. And we've adopted 2 dogs, and the one on the right is Dolce. And as much as we've tried to get him to play the piano, it's been difficult. But I will say he has this amazing affinity for Chopin and Chopin's nocturnes, and he's got this incredible falsetto. So he's a great, great singer and terrible piano player. So a little bit about my career path, because I think it kind of informs what I'm going to be sharing today. You know, I went to medical school at the University of Pennsylvania, did my training in emergency medicine at the University of Chicago, working on the South Side of Chicago. And I think that's really where my eyes opened up to how dysfunctional our healthcare system is. And you sort of see so many problems that arrive in the ER so late in the course of their disease trajectory, like patients with end-stage renal disease on dialysis that are crashing in to dialysis that are only in their late 20s or 30s, and starting to think about all the things we could have done if we were able to get upstream to prevent and mitigate illness and bad outcomes. And so that was what really interested me in population health and the intersection of healthcare delivery and healthcare financing. I subsequently did spend some time at Duke. I did an MBA, also did a clinical research fellowship, mostly doing outcomes research. And then I got recruited to go to the enemy down the street. I was on the faculty at UNC Healthcare. I spent about 10 years there and really started off as a traditional academic researcher. I had a K grant, I had an R award, published a bunch of papers doing outcomes research. And a couple years in, I just really got interested in the idea of how do we not just describe how different interventions are impacting the health of patients and costs, but how can I be part of formulating strategy to actually make meaningful changes in an academic health system? So I got really involved in being a physician executive in the health system, and I was responsible for developing, driving, leading the population health and value-based care strategy for UNC Healthcare, which was at the time about a $6 billion academic health system. And then the bottom part, I had some experience as an entrepreneur. I started a software company when I was at UNC, which I spun out and scaled and sold, and that was a good experience. And then went to Intermountain Healthcare, where the attraction of being there was this intersection again of delivery and payer and the synergy that creates. So Intermountain had their own health plan, and it really allowed us to do a lot of innovative things and align clinical care with payment. And that'll be a theme that I'm going to talk about later. And then I wanted to get pure payer experience. So I spent a couple years at Blue Shield of California as their CMO, really understanding how a health plan works and how a health plan can really be a way to catalyze new ways of working with providers to improve care and lower costs. So just a quick framing of the agenda. I think I mentioned some of this. I want to start the first part of my talk just talking about the current state of affordability in US healthcare, and it's pretty eye-opening. And I think everybody, has sound bites on healthcare costs, but I picked out the ones that for me are the most meaningful and give me the greatest sense of urgency. And it's really what's driven me throughout my career thus far. The second part is going to be about, okay, how do I translate those insights about what I know is wrong with our healthcare system to the work that I've led at various organizations? And a lot of it is really anchored to value-based care. So aligning more of the care with incentives that reward outcomes and total costs of care. And then I think I would be remiss if I didn't really provide you with some insights of what I've seen that's work, especially for specialists, because sometimes I think they feel like a square peg that doesn't fit in a round hole in traditional population health ACO models. And I had great success in collaboration working with a variety of different specialists and department chairs and specialties at UNC and at Intermountain, and wanted to share, I think, some tips for you about how to potentially navigate this space and really innovate to be ready to take advantage of the changes in healthcare over the next couple of years. So I start out a lot of talks about healthcare costs with just this quick exercise of showing you this is the average family of four in the United States. Their median household income is just shy of $70,000. It's not a lot of money to be able to clothe, feed, educate a family of four. So you can imagine not a ton of discretionary income. And then I usually ask the question, how much would healthcare insurance be worth in terms of the value that a family of four with a $70,000 income would be willing to pay? And if you think about the average family of four, they're probably pretty healthy. Maybe mom and dad have a primary care appointment. They check in once a year. Maybe they have an accident that was unplanned. They sprain their ankle. They have to go to the urgent care. The kids have wellness checks, maybe snotty nose, and they need to go to the urgent care for fever or something like that. And so the numbers that I get back in terms of what is that worth to the average family of four usually range from, I don't know, a couple $100 to a couple $1,000. And so it's really interesting to sort of get those perspectives, and then to actually toggle over to what does this family have to pay for those things that we just talked about. And the average annual premium for employer-sponsored health insurance, which is what 160 million Americans use to get health care, is over $22,000 a year right now. Now, some of that is subsidized by the employer, but more and more you're seeing high out-of-pocket, high deductible health plans where this family could be spending, if they want to maximize access to services and use of their benefit, they're spending $15,000 out of pocket, again, for an average median income of $70,000. And, you know, the other exercise I'd like to do is, in a consumer world that's not healthcare, what do you get for $22,000? And I keep waiting for the prices of used Teslas to come down where I can buy one for $22,000. But the point is, you can get pretty close to getting a Tesla for that amount of money. As a Duke alum, one of the things that I was really considering doing was going to the game last week, Coach K's last game at UNC. In hindsight, I'm glad I didn't go, because it would have been kind of a letdown given that they got killed by the Tar Heels. But I could have gotten 2 tickets pretty close to the floor, maybe even schmoozed with some of the players that were there, and that would have cost me 22 grand, and I would have thought I was getting great value for that. But in the healthcare world, you don't get much for 22 grand. My wife had this experience. We were walking the dogs about 6 months ago, and she stepped in a small hole and broke her foot. And she had a Jones fracture. And so we took her in to get seen. It was $1,385 to get a physician office visit and an x-ray, which showed a small fracture. They gave us a boot. We paid $335 for the boot. And then she elected to get surgery. And so they put a small screw, it was actually a lot smaller than that, and that was $76,000. Now, we had a high deductible health plan. I sort of rolled the dice. We're probably not going to need to spend much money. And we blew through our deductible. It was around that number I showed you on the previous slide. We paid about $14,000 out of pocket. So what does $22,000 get you in the healthcare world? It actually gets you an x-ray, a boot, and I guess technically a little part of a screw, not even the whole thing. So just something to consider. So, you know, my experience, I think, is not uncommon. And what's really interesting over the last couple of years is there's been now a new condition being described. I didn't learn about it in medical school, but it's called financial toxicity. And the picture on the left is a guy named John Crane, who was featured in a story with NPR. He was diagnosed with brain cancer. It was recommended that he be on a drug called Alecensa. It's $160,000 a year. He has Medicare. He was charged a copay of $3,200 in December. It was the end of the year. He was going to get another $3,200 copay in January. And he said, I can't afford it in December. I'm going to wait until January. He waited until the end of January because he was trying to get manufacturer assistance to help him with the medication. which he finally got. But the bottom line is he deferred treatment for 6 months, or 6 weeks. And John is not alone. We know now that a quarter of patients with cancer delay or skip treatment. And so this condition of financial toxicity is the anxiety, the negative effects related to expenses that cause harmful physical effects, mental effects on patients. And he said in the article, which was interesting, the time of waiting, not knowing whether he could get treatment, was actually worse than the diagnosis itself. And there's been some great work actually empirically studying what is the impact of financial toxicity and high out-of-pocket costs on not only treatment, but mortality. So this is Scott Ramsey in the Journal of Clinical Oncology. And I used the example of prostate cancer for this example, a really elegant study where he was able to link cancer registry records for the entire Western state of Washington to bankruptcy records from the district court, which are all electronic. And he linked them. This study went back 15 years and followed patients longitudinally. And first observation is, if you look at the cumulative incidence of bankruptcy for patients diagnosed with prostate cancer, about half of them are bankrupt within 10 years. And not surprisingly, regional and distant cancers are more detrimental than local cancers. And then he did a propensity matched analysis looking at the correlation between bankruptcy and mortality. And what you can see that the hazard ratio for death is over 2 times higher if you've gone bankrupt. So this issue of out-of-pocket costs and financial toxicity is harming patients and leading to premature mortality. And this is why I feel such a mission, whether it's on the provider side or the payer side, to address this issue. And frankly, it's not just people like John who are diagnosed with cancer. This is happening all the time for everybody. I've even rationed medications on occasion because they're too expensive and I don't feel like paying that much out of pocket. But a ton of Americans have problem paying with healthcare bills. They have to make decisions about whether they put food on the table, clothes, household items, or pay their medical bills. And it's a real problem, even for people with commercial health insurance, because of these high out-of-pocket costs. So, this is impacting consumers. If you take it up from a policy perspective, I think what I want to get home is the point that we're really reaching a point in healthcare where this is not sustainable. Everybody knows that, but it's coming soon. And so if you look in the short term, the left is projected Medicare spending. And I think, as everybody knows, Medicare on this chart is Part A, which is hospital spending, Part B, which is outpatient spending, Part D, which is the drug benefit. If you put the 3 of them together right now, we're just south of $1 billion or $1 trillion a year in spending. Within the next decade, we're going to be at almost $2 trillion in spending, almost a doubling. And a lot of this is driven in Medicare by the aging of the population. And if you dissect the Part A point, that's the graph on the right. So Medicare Part A, which pays for hospital care, is funded through its own mechanism. And there's a trust fund. And the source of funding for Medicare Part A is primarily through payroll taxes that all of us pay. And what we see is that actuaries now say that by 2026, the Medicare Trust Fund will be completely exhausted and will go into a deficit. And so what that means, there's no provision in the Social Security Act for how to deal with this situation. So we're reliant on Congress, which is a scary proposition right now. But really, there's only 2 levers here to fix this problem. We got to raise taxes a significant amount, or we have to cut payment rates for Medicare or restrict access to services. And so This is going to get sorted one way or the other, but for any of us who are going to be practicing medicine in 2026, and I think that's most of us, we'll be experiencing this policy issue in a very direct way. And if you want to geek out on debt, go to usdebtclock.org because it'll blow your mind. So not only do we have $30 trillion of debt, but it just reinforces how big of a component Medicare is to the long-term fiscal issues of our country. Medicare is the unfunded liability for the next 70 years in the Medicare program is $34 trillion. So for those of us who are on the younger side of the generation, you'll be dealing with this your whole life. And then I find it fascinating. Medicare does this calculation of the unfunded liability over the infinite horizon. And I couldn't explain to you how they actually do that. But that number is $103 trillion. So good news is it's only an estimate. Could be lower, could be higher, but it's a lot of money. And again, underscores the issues around Medicare. I want to talk for a couple minutes about how we got here, because it really is important to understand for how we go forward from here. So great article that I think many of you probably saw by Atul Gawande called, it was in the New Yorker, Overkill, an avalanche of unnecessary medical care is harming patients physically and financially. Bottom line, we have a healthcare system that pays for illness. It pays for transactions of care. The more we do, the more complex the interventions are, the more we get paid. Doesn't pay to keep people healthy. And that's what's driven a lot of the issues with costs in healthcare. On the right is an example I think you can resonate with. This is from the Dartmouth Atlas, which has done a lot of the work on geographic variation in care. And it's the rate of prostatectomy per 1,000 male beneficiaries age 75 and under with prostate cancer by referral region. And so the first thing you notice is that the surgery rates vary tenfold between referral regions, like between Munster, Indiana at 480 and Ocala, Florida at 55. And I would say the rates for screening and diagnosis, you see a similar 10 to 15-fold variation. So for a condition like prostate cancer, you would expect some variation because the treatment is based on age, risk factors, patient preferences, and your specialty has done a really good job incorporating those. But what the analysis shows, so that's good variation and variation that we expect to see. But the analysis shows that most of this variation is due to provider and site level characteristics, not the good type of variation that I described. So it's unneeded variation. And I think this is really instructive for urologists too, because of all the different surgical conditions they studied in the Dartmouth Atlas, prostatectomy had the biggest variation of any of the other surgical procedures that were studied. And here's another way to look at the same issue, and it's decomposing Medicare expenses. And so anyone who spent time doing population health and value-based care knows we spend a disproportionate amount of expenses on a small number of people. And so the text is really small here, but what I'll do is sort of walk you through what this graph shows. The blue bars are deciles of spending in Medicare. So the first decile on the left are the sickest people who spend, on average, the per capita spend is about $180,000 a year. So you're going to see a lot of transplant, end-stage renal disease, catastrophic events in that box. And what you see in these first two deciles of spend, they account for a large portion of Medicare spend. In fact, that big gray box on the left, 50%, but there's only a very, very small number of people that are actually in those deciles of spend. In fact, the first bar, that represents only 0.27% of the population. So we're spending all our money on sick care. And if you move to the right, the 9th and the 10th deciles of spend, that's 82% of the population. So I would argue we should be spending a little bit more, maybe a lot more, on people who are well, keeping them healthy, and then identifying them earlier in the trajectory of disease in order to get more to a value-based construct and realign incentives. And if you want to think too about the value of health insurance, it's the people on the right that are paying the premiums to support, obviously, the care of people on the left, which is largely sick, medically complex care. So it's just another example of how we've gotten where we are. A quick comment on the commercial health insurance market. It's a bit different than Medicare. And I can't say it any better than Uwe Reinhardt. He's a famous health economist. He's got a great, relatively new book, which was published since his death, that I would recommend everybody read because it gives you great insight into these issues. He told us in 2003, it's the price is stupid. And the same authors, minus Uwe Reinhardt, told us the same thing in 2018. So when you look in the commercial market, it's less about utilization and it's almost all about price markups. So what goes into price are local factors, so input costs, labor, and materials. But the biggest part is the markup. So that's what's negotiated between provider and payer. And if you look at the red dot, this is in Medicare, you see that price markups and service price and intensity specifically. So service price is the absolute price, service intensity is the medical complexity of that procedure, which affects the price. It accounts for about 70% of the overall variation in price. And what's interesting is, despite the aging of the population, those factors account for proportionally much less than price. And so what's happening in the commercial market, and this is a study from RAND, which is eye-opening, is the commercial insurers are really just leveraging higher rates on the commercial side. And so this is the ratio of commercial versus Medicare payment rates, and the x-axis is states. And you see that on average, commercial payment rates are 250% of Medicare. We see some examples where for certain types of high-cost infusion medications, we're seeing rates of 500 to 1,000%. And so this has been a way that the markets have functioned, but there's only so long that we're going to be able to keep increasing rates at this level above Medicare rates in the commercial market. And I think the other thing, I was talking to Marshall a little bit about this before we started. So the big issue is we pay too much for sick care, not enough for healthy care. And the reality is there's also a lot of people in our healthcare system that profit from it and don't necessarily add a tremendous amount of value to the value chain. And this was an article from the New York Times about how our healthcare system is really an engine of inequality and one that we need to address. So where we really got started with payment reform, and this is where providers and payers really started to step up their game, was the Affordable Care Act. And one of the things the Affordable Care Act introduced was new payment models. So moving to things like accountable care organizations, where groups of providers would be responsible for managing an entire population of patients, improving outcomes, reducing costs, and then being incentivized to reduce costs. And it was about this time at UNC Healthcare where I got really involved in talking to our leadership about strategically the importance of heading this direction. And this is really kind of the value proposition that I had for myself and that I shared with a lot of our physicians at UNC Healthcare about the choice between staying on a current path of just working in a fee-for-service transactional model versus moving towards a different model where we could take care of patients in a different way and get paid in a different way. So the current path, what I see is downward pressure on fee-for-service rates. I think based on what I showed you with Medicare, they ain't going up, they're going down, most likely, or they're going to be going up at much lower rates than we've traditionally seen for the near future. Again, the current system focused on maximizing transactions. It has the effect of fragmenting care for patients, and I think also frustrating a lot of providers. A lot of the providers I worked with at Intermountain at UNC sort of described the hamster wheel phenomenon in terms of how they felt. And then the alternative is the more premium dollar you control, in other words, the more dollar that's prepaid, where you can assume risk for total costs of care, you have more flexibility to design programs to really integrate that care in a different way than you do in a fee-for-service system. There are opportunities to really develop programs that maximize health. I found that providers are a lot more likely to engage in developing new care models that achieve these objectives. And the last part about innovative and grow, and I think you'll see this come through on some guidance I have about working with insurers and large employers. If you can do this really well, it will be very attractive to payers and large employers who self-fund, that want to work with providers in different ways that drive better value and drive lower costs. So I'm not going to go through this in detail, but CMS has outlined a very nice framework about how to think about value-based care and payment reform. And essentially going from the left all the way to the right is moving from pure fee-for-service to category 4, which is essentially capitated risk. And there's some interesting space in between. So category 3 are alternative payment models that are built on a fee-for-service architecture, but providers can still take upside or downside risk. So if costs exceed or come below a certain threshold target, they could either share in the savings or losses. And that's a really good way for organizations to participate in these efforts. And I think your organization has an ACO. And we're actually seeing pretty rapid traction across the country. I think some folks would like to see it move quicker, but clearly in certain segments, like in Medicare Advantage, more than 50% of payments are tied to advanced alternative payment models, where providers are assuming some of the downside risk for total cost of care. And I think we'll see this continue in the near future. So the challenge I pose to our physicians at UNC is, what I'm not saying is you need to scuttle your existing fee-for-service business, because I'm sure it's performing admirably in many ways and allows you to do a lot of the clinical care, teaching, and research that makes you a world-class institution. What I am saying is that the market is changing and will changing. And so this is more about optimizing your fee-for-service enterprise and supporting the development of a new business model that's going to be increasingly important in the future. And of course, all of this is in the face of significant market uncertainty over timing and trajectory, but it's going to happen, and no one knows how hard, how fast, but clearly we're moving in this direction. So just want to spend a minute maybe talking about my experience at UNC Healthcare. So the strategy there was thinking through how to build out this population health and value-based care model. And I'd say there were 2 key levers. One was, how do we work with our providers, not only our employed providers, but if we're talking about populations of patients, they live in a lot of communities where we have non-affiliated independent providers on our medical staffs that are also supporting the care of those patients. So part of it was developing a leadership and governance structure. We had a board dedicated to these efforts that was almost entirely physicians. I think it's important for this work to be physician-led, and obviously also supported by key executives and non-clinician administrators. We contracted with, as you can see here, about 1,200 primary care physicians and over 4,000 specialty providers across the state, developed new clinical and operational infrastructure to support things like complex care management, tools to collaborate and share information and data. And then a clinically integrated network, by definition, is leveraging these efficiencies to provide better care and lower costs. And by doing so, can then jointly contract with payers. So as a combined entity, we were entering into contracts with organizations like Blue Cross Blue Shield of North Carolina for commercial business and negotiating value and risk-based payment arrangements. We also entered into risk-based payment arrangements with Medicare. We had a next generation ACO and took downside risk. And it was this physician engagement and development of new care models and new ways of actually paying physicians that really made a big difference. When I went to Intermountain, it became even easier because we had a health plan and it was really easy to align incentives. So one example is we created a new model of primary care that was not based on RVUs, but it was a salaried model. And we basically had all of our high-risk patients that we were fully at risk for. And we organized team-based care and created new incentives around quality and total cost of care. And that made a big difference as well. So a lot of experience with that. We also moved a lot of care into the home. And I think that's going to be a theme that we're going to increasingly see. So I mentioned the importance of governance, developing new IT and data analytics systems. You really need to be able to risk stratify populations. Financial management becomes really important. And this is, I think, both internally, how do you do premium accounting versus traditional accounting? So you're getting a pot of money at the beginning, not generating transactions and getting pieces of money over time. So you have to think about different things in your revenue cycle and your compensation structure. Network management is also important too, because in Medicare especially, a lot of the costs are incurred in places that you can influence, but are outside of your direct control. So post-acute care facilities is a great example. A lot of spend in the Medicare space occurs there. And unless you really understand who your partners are and how they're performing and how you work together, it's really hard to move the needle on value-based care. And I think most importantly, you want to do it as a coordinated effort. A lot of times it felt like this. And that's why I think that mantra of we're not scuttling the current business, we're figuring out a new business model and trying to move that direction over time. So 5 quick thoughts, and then I'm going to wrap up. A path forward for specialists. I think about how you can take an ownership and a seat at the table, how you can excel at managing what's in your direct control. And I think about episodes of care and bundles of care, how you can collaborate with other clinicians, especially primary care physicians, to help them manage total cost of care, invest in and adopt new models of care, and then forge innovative partnerships with key stakeholders, especially large employers and health insurance companies. So take ownership and seat at the table. There's a lot of people that have taken credit for this quote. If you're not at the table, you're on the menu. Most ACO boards actually had mostly primary care physicians. I intentionally set mine up that half of the individuals on the board were specialists. So that's Dr. Pruthi, who played a critical role. Hadley Calloway was an orthopedic surgeon. Rig Patel was an interventional gastroenterologist. Rob Wiebe was an oncologist. I just realized they're all men. I did have good gender balance on my board, but this subset of specialists happen to be all men. But I would say the evolution of going from being at the table to protect their turf, and I think they would all admit maybe that's why they were there at first to some degree, to getting to, over a period of time, really working together in a collaborative way to figure out how do we navigate this transition and how do we make care better for patients and how do we be successful in the future world about how medicine is going to be practiced and paid for. And so I would say look for opportunities to be at the table, whether it's on your ACO, whether it's professional societies that are moving this direction. It's just really important that your voice is heard. Excel at managing what's in your direct control. I use that example of prostatectomy. There's obviously a glaring opportunity to do a bundled model where you just get religious about sort of knowing every input and sort of value driver in that chain, and you can ensure that your patients are having optimal experience, optimal outcome at the lowest cost. On the left is just some data. We have more data from the orthopedic joint bundles through a lot of the national programs. And one of the biggest observations was, they've lowered costs in many settings. And on the top was the proportion in the first couple of years of doctors that the proportion of patients that were discharged to post-acute facilities for the different doctors. And in the program that incentivized total cost of care, you saw a shift in 80% of the doctors were now basically discharging to home-based settings, not higher cost post-acute settings, and their patients were getting equally good, if not better outcomes. The study on the right I love, and actually I think it's from your department, and I wasn't looking for a study from your department, but this is the one I found, looking at variation in supply costs for open partial nephrectomy. And not going into it, it just basically demonstrates there's a lot of variation. Again, some variation is good, some variation is probably unwanted, and there are ways to address this. I'd be really curious to know what's been done since this paper was published. We did a lot of this work with our cardiologists at UNC, our interventionalists, who we did a similar thing with their PCI procedures, and we saw over time a convergence towards a greater acceptance for a best practice and doing this at lower costs. And so when you start working with payers and bundled payment models, that's going to be really, really important, because the total cost you get paid is going to be less, but you're going to get volume. And if you can make margin on that volume, then you're going to do very well financially. I mentioned the importance of working with primary care physicians, especially primary care groups. Increasingly, they're the ones taking risks in these ACO models because the patients are attributed to them, and be thinking about ways that you can collaborate with primary care physicians. This is awesome work that they did at the LA healthcare services, where specialists are limited. So they basically implemented something called expected practices. They work with primary care physicians to say, what are the indications to refer to a urologist? Do you need to refer every patient with hematuria to urologist, or can you manage that workup on your own? And if you do need to refer, what do you need to refer? And how do we make sure when they get here, we can figure out what's wrong with them because they have the right tests ordered. We don't have to repeat stuff. And basically this process dramatically lowered the wait time and reduced the overall need for urology input. And a lot of it was delivered virtually. And of course, you need a new way to get paid for this. So you need to get credit for this work. And if you're working with an organization that's taking risks, they should be putting money towards these types of efforts. Real quickly, I mentioned home-based care. You'll see more and more care shifting into the home. We were doing hospital at home in Intermountain. They're doing it in many locations for low-cost admissions. But without doing something as complex as a hospitalization, think about how to use technology to see your patients, to follow up with your patients, to do a whole host of other things that allow you to work more efficiently. And then lastly here is, I mentioned the importance of the partnerships. Many large employers right now, you have the most mature purchaser group, the purchaser business group on health, representing a lot of jumbo employers out here on the West Coast. They want to work directly with high performing organizations. They have a center of excellence program for spine surgery, cardiac surgery. A lot of companies are using them. Again, they pay a lower price, but if you can do this really well, you're going to get a lot of volume. And then working with health plans, I can say when I was at Blue Shield, we loved working with forward thinking specialists that wanted to work in a different payment construct. We were working with cardiologists around bundled payments for procedures, orthopedic surgeons, oncologists. We were doing bundled payments for cancer diagnosis and radiotherapy. So I think there's a great opportunity to engage with urology, either directly with you on the plan side or, with a professional society partner. And then lastly, I'll leave you with the thought about taking a bias to action. I don't think the model on the left is going to be working 10 years from now. So, and I don't think your old business model will be eliminated competitively, but somewhere in the middle, you're going to need to start moving to a new one. And I would start thinking about moving now so you can control what this looks like in the future. How's it going to turn out? I don't know. I'll defer to two of my favorite people, Yogi Berra, who says prediction is very hard, especially about the future. But I think Michael Burry, this is the guy that the movie The Big Short is about, called the 2008 recession. Did a lot of trading of credit default swaps and made hundreds and hundreds of $1 million. And he says it's ludicrous to believe that asset bubbles can only be recognized in hindsight. So I would apply Michael Burry's thinking to some of those slides that I showed you with the sustainability of healthcare, and think about whether it's going to be important to think about your own practice and profession in a different way. And then philosopher said, if you don't change direction, you may wind up where you're heading. So I'll leave it at that and turn it over back to Marshall to see if there are questions. Sorry, I went a couple minutes over.
No, Seth, we really enjoyed that talk. It was great. Few questions from our faculty. Tom Chi said, you mentioned the idea of working carefully with your payer. Let's take Medicare, for example, to be successful with bundled care strategies. Can you elaborate how departments, as part of an academic center like here at UCSF, can do this most effectively? In particular, how does the Department of Urology do that to negotiate separately with these insurance companies?
Yeah, I would think about, first identifying, the areas that you think drive the greatest value or could drive the greatest value for a payer. And then I would engage in a direct conversation with that payer. It's usually either the chief medical officer or the person that's responsible for value payment transformation. And then I think if you're working with a good plan, they should be able to have an open discussion with you about the opportunity. And I think also, provide data and information in a collaborative way that allows you to get some perspective in terms of their historical cost and claims experience. And then I think from that, you could get to a scenario where there's a bundled price that's mutually agreed upon, and quality measures that are associated with that bundle to make sure that members are still receiving high quality care. And I think most good plans will pilot that. We always piloted programs at Blue Shield to make sure they're working as intended for the provider and for the patient, and then potentially scale them from there. So that's how I think about it.
So let me just repeat that and rephrase that. You're sort of saying that then maybe you go directly to the insurance companies and at least give your proposal about what you think would be a reasonable bundled plan so that both parties win.
Yeah, I think so. Go in with a plan, with data and information, and then ask for what their data and information shows about the same problem. And I think then from there you can really put your heads together and figure out what to do.
That's helpful. Sam Washington had a question. At the population level, we see a broad variation in healthcare spending, not only by geographic location or region, but also across demographic characteristics such as race, income, et cetera. So that a small subset have an excess spending while others, some sick, some not, have the excess testing, continue not to have access to health care. Do you have any thoughts on how to limit excess in that subset while allowing access to healthcare for those who do not have it?
Yeah, it's a really challenging issue. And I think you hit on a really important point. I think one is having a holistic approach to addressing the needs of those patients and social determinants of health. So a way to screen for things like food insecurity, people who need transportation assistance to get to an appointment, and then having a program that can support them in those needs, because we know that 90% of healthcare costs are driven by social and environmental factors, not by the actual care that we deliver. And then I think either in a traditional medical practice, or I've had great experience using community health advocates, which are sort of lay people that are trained to be a community health advocate, but they work and live and in the communities that a lot of these patients are located, and can help them with just sort of daily needs in terms of like getting and taking their medication, for example, getting to their doctor's appointment. And so I think those types of interventions are relatively low cost, but I think can have a big impact overall. And I actually attribute investments in programs like that at UNC to some of our success in population health.
On your talk, a few folks have asked, is the Kaiser system of Northern California sort of an integrated system where they obviously get a bundle of money up front and they are pretty good at integrating, meaning that all the healthcare providers in general are associated with Kaiser along with everything else, whereas when you have like UNC or Intermountain Health or UCSF, we have a lot of referrals coming from outside, this area, and we have to manage them. So how do you sort of incorporate those two, the Kaiser model versus a tertiary center model?
Yeah, so that's correct on Kaiser. So I did this work at two other organizations that were different from Kaiser, and I think more like yours, especially the first one. UNC was a statewide medical center that had 2,500 employed physicians, but had 10,000 plus affiliated physicians on medical staffs or in the communities. And so I think it was identifying in that model who were the important physicians in terms of like referral volume, or particular communities that were of higher importance. And then I think working with them to develop some of these programs. I mentioned the expected practices. So for an underserved community in an important area, can you work with them on care protocols in terms of when a referral is indicated or when you can provide virtual assistance so that patient has access. And if you're doing things like that, even with independent providers, there is a way then as a function of that clinical integration to participate or to contract with a payer that includes parties that are not just employed by your organization. So I think part of it is, to sum it up, part of it is prioritization in terms of figuring out what's most important to you in terms of who you want to work with and how you want to work with them in terms of what you're trying to accomplish. And then I think looking for ways to jointly contract or organize those teams of clinicians in a way that you could contract with a payer for savings if you meet a certain threshold target or some other types of incentives.
So do you think that the RVU model for reimbursement is a dinosaur, or is that model still appropriate in 2022?
I think it's still appropriate in 2022. And so I don't think it's a dinosaur. I think over time it will become probably less prevalent in terms of, like, I don't think it'll go away, but I'd say in terms of how much of your comp model it drives, it will become a lesser part. One of the main things I did at Intermountain was revise the compensation structure for our medical group. And when I got there, about 80% of the comp, actually 90%, was tied to RVUs. 50% of the revenue was capitated fully at risk. So it made no sense to have that discord. And so I worked, it was very hard work. I had to get a lot of physician buy-in and support, but we de-emphasized RVUs in our revised comp model. They still made up at least half of the comp model, but there were much bigger components related to quality, managing medical costs, because we had more at-risk contracts. And so I think as long as you're getting fee-for-service payment, you need to have RVU in there, because you need to have a viable business. I just think it's going to need to adjust over time in terms of how much it drives. And then we also thought about, creating two sets of primary care physicians, one who wants to practice in a transactional model, and one who just wants to manage high-risk patients using a more heavily resourced team and is paid a salary with big incentives around quality and other things. And that's a model too to consider, because sometimes people get, it's hard when you're caught in the middle. You're sort of 1 foot in the boat, 1 foot in the dock, doing fee for service and value. And so there are some ways to think about that strategically, where you're sort of creating a new program or new physicians that are really focused on the value and have a totally different comp model, which may eliminate RVUs altogether, if that makes sense.
Well, Seth, I think I'll speak for all of us. We really enjoyed your 30,000-foot view of where healthcare is going right now, and I want to thank you for your time and perspective. And thank you very much.
Yeah, thanks for having me. And if anybody has questions or wants to follow up, then I'm happy to speak to anyone offline after. So
sounds good. All right. Thanks, Seth.
Thanks,
have a good
everybody.
day. Thanks for your time.
Well. Thank
Bye-bye.
you for having me. Take care.
Bye-bye.
Bye.